Hi, and welcome to my case study presentation. So, my study was done on a white female, 21 years of age. She has a history involved with child welfare programs. She has a history of homelessness and mental illness leading to hospitalization. There's a lack of stable relationships between parents and partners. She currently has an 11-month old that is in foster care. And the way that she views her situation right now is that she believes that all providers are who are working with her are causing her any ailments, and they're the reason why anything bad is happening to her. And it's the provider's responsibility for fixing everything, not her. So she just kind of has this negative view on life and on her situation currently. So, relevant information from working with this client and this case on my own. Um, she has this constant worry and wonder if anybody wants her. She thinks about her mom and her foster parents and her own biological mother. And, she kind of in conversation will ask, I wonder if they would let her stay with them, or if somebody would even want her. So there's this constant like need to be wanted somewhere. She makes statements to all of her providers like her limbs need to be removed and she can't leave her home because the ones who are working with her are making her physically disabled, and a lot of comments that are kind of out of the ordinary, that you would expect to have when you're trying to provide somebody assistance. She has difficulty with engaging in conversation and holding conversations for more than 15 minutes. Typically, the conversations become very negative perspective, and she starts lumping everybody together as your CPS, you took my child away, you're the reason for this, and other things like that. She does not like going out in public and repeatedly does not make her required appointments. So this leads to her being hospitalized at least once a month. She's picked up by her by law enforcement and brought to the hospital to be checked out. She she is supposed to get monthly injections, which she typically does not get, but when she does get them, her thoughts become more clear, and you can kind of have a conversation for more than 15 minutes, and she shows understanding of what is required of her. And then the just the with working with her, the constant hospitalization and the very short attention span make it very difficult for almost all of her providers to get just a better picture of her life and what's actually going on, and the best way to help. It's very difficult, and it provides a lot of barriers to providing her assistance. And so the best way to kind of figure out information about this client is by using collateral contacts, which has been very useful, but even with that, there are still many gaps that need to be filled in about her history or about what's happening currently, and just about her and her life. It's There's still some things that are missing, so it makes it a little difficult to know the full story. So I want to note some strengths and some resilience about this client. Her strengths is that, when she is medicated, she can reiterate the importance of everything that her providers are assisting her with, and the importance of her to actually engage and work with her providers. So there is hope that if she sees this and feels this way when she's medicated, she'll continue to stay medicated and be able to recognize all of these on her own instead of having somebody tell her what providers are helping her with and then she just repeats it back. So there's hope for that. And then as far as resilience goes, she has had a very tough childhood being in and out of foster homes until she aged out at age of 18. So, she was moved around a lot, not a lot of stability. And even currently now, she's still facing instability in housing and relationships, and it's just really affected her. But she remains hopeful, and she really does see she's able to see positive in all of the negative that happens in her life. So she's really hopeful that one day she will have a family and she'll be able to have her child back home with her. So, as far as my diagnosis with the DSM-5 and how she meets the criteria, so between me and all of her providers, it has been acknowledged that she most likely suffers from schizophrenia. She meets delusions, hallucinations. Those are with her, her thought processes, and what she thinks about, and how she kind of makes up things that are happening to herself and in her life. And when you kind of try to bring those things up, she just acts like she didn't say that or it didn't happen. So there's this constant thought process and pattern that is just not the same. It's not stable. She has disorganized speech. You can tell this especially because she uses text to speech. So in her text, you can kind of see her derailing when she has a thought process and then it just kind of goes into a whole different topic of conversation just in the middle of the text. Or you can kind of see this like difference in what she wants and she doesn't fully know what's happening or what's going on, so she just kind of changes topic very fast, and it's very hard to understand what she's saying or what she wants. And then her negative symptoms, these are all seen in the delusions, hallucinations, disorganized speech. And then she meets criteria B, which is her level of functioning in one or more areas is markedly below level achieved prior to onset. So the way that she meets this one is actually because from collateral contact, she's had the same symptoms for a very long time, and especially in childhood. And there has been no increase in her ability to maintain relationships, to maintain a social life, to hold a job, hold a stable job at least. So a lot of her areas of functioning are very low and below standard what we'd like to see. She has been in she's been working with providers for about 11 months now since her child came into care, and there has not been a period of time where she has been like not non-symptomatic. So it is persisted for more than 6 months. it I was able to I and her other providers have been able to rule out schizoaffective disorder and depressive or bipolar disorder with psychotic features. She has not had any like manic episodes. All of her symptoms and presenting the way that she presents has been the same. There's not been above or below baseline. She just kind of presents as this the way that she does normally. And E, the effects are, it is not attributable to physiological effects of a substance or other medical condition. The answer is no, because it is not fully known whether there are substances at play when it comes to her symptoms, but because we know as her providers that there is occasional substance use, but there have never been any tests that can prove it when she has become hospitalized. So the only thing that we can say is that there is no substance abuse that is causing these effects and these symptoms. And then there is not a history of autism spectrum disorder or communication disorder that has been brought to our attention. So that has been ruled out, and she meets the criteria that is required for F. And then she has also catatonia associated with schizophrenia because she has these relate to all of the A's. She has negativism, posturing, mannerisms, and stereotypy. A lot of her presentation, when you were working with her, she has very, very abnormal body movements, and she holds her body in weird ways that you would not expect to see somebody when you're having a conversation with them. Again, a lot of her thought processes are very negatively based, and it's very like one tracked. And yeah, a lot of the way that she comes off, it's very unnatural for how you would expect somebody to be behaving. And then, so the framework and framing question, so cognitive theory is what I chose as the framework, and it'll guide the use of cognitive behavior therapy. So, what the way that, using this framework with this specific client, it'll help contextualize challenges experienced with managing her thoughts and how she perceives them. She, because she struggles with her thoughts about the world and people who are in her life, to help her, it'll kind of help, using this theory and this framework will help her to better understand the way that she's thinking and her thoughts. And also she has many negative perceptions about what is happening to her and what she thinks is happening based on her past. So being able to work through this and, use her thoughts and kind of work through them with her is going to be the best way, I believe, to work with this client. And based on the framework, the framing question would be, is this thought based on fact or based on feelings? So cognitive behavior therapy will help her have insight and come to conclusions that are not misinformed by her feelings or beliefs, and working through how her past experiences are affecting her current thoughts and how her current feelings and beliefs are misinformed. So this would be done through cognitive restructuring, which asks these three questions, which is, what's the evidence, what's another way of looking at it, and what are the implications of having this belief. So by having her, what is your evidence for this thought? Saying that I can't leave my home because you guys are making me ill. Like, what is the evidence of this? And just kind of having her work through this process and helping her restructure her thoughts, and show her that, her thoughts are not based on facts, they're based on the way that she's feeling. I would also recommend potentially going the medication route, because we already know that working with her when she is medicated, she is able to have a clearer understanding of things in the present. So using the medication route would probably benefit her as well as using cognitive theory and this cognitive behavior therapy for her. So, my final thoughts on working with this client is that I really have learned the importance of collateral contacts and learning more information from them, and also not feeding into delusions or hallucinations, and just kind of keeping the conversation very focused, and keeping your words very purposeful is a great way to kind of help help the client stay on track and not kind of lose their own thought process or allow themselves to go into another state of mind. And also being able to direct a conversation, and just being straightforward and to the point, to avoid allowing like off-topic conversations or allowing for the client to twist your words, is something that I learned to work through and work with for this client especially. And just kind of being able to help in general, and seeing this client get help has been like really hopeful for working with somebody who has or suffers with, like, from schizophrenia. So just I've learned a lot from this client, and I hope you all enjoyed my presentation. Thank you.